Greetings. Let us talk about how to assess severity of a patient admitted with acute pancreatitis. And I would like to recommend you to read this article about acute pancreatitis that was published in the New England Journal of Medicine in 2016. It's an excellent article to read. So let us take this patient. This is a 70-year-old man. He's obese and has a history of hypertension, diabetes mellitus, and he has recovered from a stroke, and he presents to the emergency room with acute pancreatitis. The diagnosis was based on his classic pain history and elevated amylase and lipase more than 3 times the upper limit of normal, and a CT scan showing acute pancreatitis. So with this story, let us look at how do we assess the severity of acute pancreatitis. For that matter, when it comes to assessing severity of either pancreatitis or any other problem, there are three important uh, parameters you want to look at. One is the patient. Next is the pathology. And third is the impact of that pathology on various organs or on the body. So keep this thing in mind, whether it's acute pancreatitis or pneumonia or a heart attack, uh, whatever it all boils down to who is getting affected, what is the problem, and what is the impact of that problem on other organs. So let us now focus on acute pancreatitis. And as you can see, this patient is 70 years of age. He is also obese. He has several comorbid conditions. And then he presented with acute pancreatitis. So whether it is acute pancreatitis or some other problem, advancing age above 60 years, is certainly a risk factor because the body has gone through aging process with issues related to aging. And whenever somebody has underlying obesity, it is a big risk factor for a lot of problems. That is something to keep in mind. And whenever someone has several comorbid illnesses, hypertension, diabetes, and target organ damage from these two conditions also increase the risk. In other words, you're seeing acute pancreatitis in a patient's body that has already been gone through some wear and tear. So think about that in those lines. First is the patient. Next is you're looking at some vitals when the patient comes in. You can see the patient has a low blood pressure. Patient has tachycardia with a heart rate of 120 per minute, and he's also breathing pretty fast, 22 uh, times per minute. And you look at his temperature is elevated. Uh, so vital signs do help us to figure out about a lot of different things: your cardiovascular function, your respiratory function, and it also tells about indirectly about whether there's ongoing inflammation. So you look at the labs and you notice that the white cell count is elevated. So why am I posting these things? As you can see here, there are lots of signs, vital signs that do tell us about underlying inflammation. So, in the setting of acute pancreatitis, when the pancreas gets inflamed, the inflammatory uh, mediators released by the autodigestion of pancreas cause systemic inflammatory response syndrome, or otherwise known as SIRS. And how do you diagnose systemic inflammatory response syndrome? You look at the vital signs. If the temperature is either low or high, if the heart rate is above 90 per minute, in other words, tachycardia, and if there is increased respiratory rate of about 20 or above, and also if the white cell count is either low or high. These parameters do suggest that the patient is having underlying systemic inflammatory response syndrome. So, when you look at a patient, you look at the patient's comorbid conditions, whether the body has taken a wear and tear. And then by looking at the vitals, don't just think about, hey, tachycardia, blood pressure, and other issues, but think about what else is happening by putting pieces together. So, we have learned about systemic inflammatory response syndrome. In the setting of acute pancreatitis, these different signs are a reflection of pancreatic inflammation and release of free fatty acids and cytokines into the bloodstream that in turn create this systemic inflammatory response syndrome. The next is, let us look at one other vital sign, and that is in this patient you also notice that in addition to tachycardia, rapid respiratory rate, temperature elevation, we noted that the blood pressure is low, 90 by 60. So a low blood pressure indicates that the uh, patient has decreased hypotension, and if the hypotension could be due to different factors, either the heart is not pumping well, or there is not effective circulating volume because of loss of fluid due to third spacing, especially in the setting of acute pancreatitis, loss of volume because of either blood loss or fluid loss, uh, or low blood pressure could be due to obstruction to flow, like a pulmonary embolism. So you have to think about low blood pressure in these different, thinking about these different four concepts for low blood pressure. And in acute pancreatitis, the low blood pressure is usually due to loss of fluid into the third space and decreased circulating volume. You also notice that the labs show a hematocrit of 48%, that is elevated, a BUN of 40 milligrams per deciliter, and a creatinine of 2 milligrams per deciliter. A few months back, his labs were normal. So, what do these parameters indicate? These parameters indicate that the patient had acute pancreatitis with a lot of third space loss of fluid, resulting in decreased volume, uh, circulating volume, and hypotension. And because of loss of fluid in relation to other components of the blood, there is hemoconcentration. So a hematocrit of above 44, a BUN of above 20, and a creatinine about above 1.8 milligrams per deciliter. All these features indicate that there was severe third space fluid loss. And we've learned that this is because of the adverse effect of the cytokines and free fatty acids on the blood vessels, making them leaky. So, we have learned about a lot of things by looking at this patient. We figured out whether the patient is healthy or has had issues because of his age, obesity, comorbid conditions. And we looked at the vital signs and white cell count and learned about systemic inflammatory response syndrome. And we looked at the blood pressure and we looked at the hematocrit, BUN, and creatinine and learned to think about fluid loss and third space fluid loss. So, with this understanding, let us talk about acute pancreatitis. So, when somebody comes in with pain, upper abdominal pain that is severe and persistent, lasting for a few hours or several hours, along with nausea and vomitings, and the pain radiates to the back, and amylase and lipase are elevated more than 3 times the upper limit of normal in your lab, and the CT shows pancreatic inflammation. That is acute pancreatitis. So, when you see acute pancreatitis, you have to think about several different things to manage this patient. So, is there a systemic inflammatory response syndrome or is there a significant hypovolemia? We already talked about it. You also want to find out if there is organ failure of either the cardiovascular system, respiratory system, or renal system. And after the first few days, you also want to ask the question if the patient has uh, responded to the treatment and if organ failure is only transient or ongoing. Ongoing organ failure beyond 48 hours is a bad prognostic sign. Next, you ask about is there pancreatic necrosis by doing a CT on the third day or fourth day. CT scan done immediately after diagnosis within the first few hours will not show pancreatic necrosis. And then you also want to ask is the pancreatic necrosis also getting infected or not? This usually happens, infection sets in pancreatic necrosis usually after the second week. So as you manage the patients with pancreatitis, you want to keep about all these different parameters. And as we see a patient in the ICU and you want to figure out whether the pancreatitis is severe or not, there is a scoring system that is available that is known as modified Marshall score for organ failure. Basically, we are looking at the impact of acute pancreatitis on the cardiovascular system, respiratory system, and renal system. And you look at the blood pressure uh, of the inotropic support to assess the heart function, the uh, ratio of PaO2 and FiO2 for respiratory system, and the serum creatinine level to assess the renal function. And you give a scoring from 0 to 4. So, to just go through this, when it comes to assessing the cardiovascular system, a blood pressure above 90 millimeters of mercury off without being on any inotropic support is a score of 0, and below 90 millimeters of mercury, but it responds nicely to fluid challenge, that is a score of 1. And if it doesn't respond to fluid challenge, it is a score of 2. And with hypotension, the next step is impaired tissue perfusion, leading to lactic acidosis. So, along with hypotension that is not fluid responsive, and if you notice acidosis, depending upon the severity, it is a score of 3 or 4. So, in other words, you're looking at, is the blood pressure okay or not? If it is not okay, can we get the blood pressure up with fluid challenge or not? And then looking at tissue perfusion and seeing the degree of acidosis. So think about the circulatory system, perfusion into the organs, impaired perfusion, lactic acidosis. So if you think about that, you can actually conceptualize the management of patients better. So now let's go to the assessment of the respiratory system. When it comes to that, you look at the arterial blood gas oxygen level, and you look at FiO2, and you look at whether if it is more than 400, that is good oxygenation. As the lung develops a non-cardiogenic pulmonary edema, the oxygenation uh, starts to dip, and with each drop, if it is less than 400, 300, 200, and 100, you have different scoring systems. So now let us move to the renal system. And you're looking at serum creatinine. If it is less than 1.4, 1.4 to 1.8, and 1.9 to 3.6, 3.6 to 4.9, and above 4.9. That is a score from 0 to 4. So as you can see here, we are assessing the cardiovascular system, the respiratory system, and the renal system, and different scores. And if the score is 2 or more, that indicates that there is organ failure. So in summary, we have learned about assessing severity of acute pancreatitis, but I also tried to give you the concept of assessing severity of any illness. Think about the patient, healthy or not healthy to start with. And number 2, severity of the particular organ damage and impact of that organ damage on other organs. So when you think about that concept, it helps to manage any patient. And in this case, we used acute pancreatitis to learn those concepts. And I hope this is helpful. Thank you.